Welcome to this episode of Let's Talk, where we zoom in on the practical applications and the key learnings of some of the most talked about sessions in this Monaco Congress. In this case, we are talking about treatment planning of full arch reconstructions, reducing times, improving outcomes, ? My name is Gerrit Heijkoop, and I'm very honored to be joined by the chairs of that session, Luca Cordaro from Italy. Welcome, Luca.
Thank you.
And here from Spain, José Manuel Navarro. José, welcome.
Thank you, Gerrit. Thank you.
Now, this title seems to have some kind of intrinsic dilemma in it. Reducing time, ? Improving outcomes. Luca, is this something that is opposing efforts?
Now, I have to say that I think that what came out of the session is that most of our speakers were proposing immediate implant placement and immediate loading. At the end, it was not a matter of choosing the timing, but it was more a matter of discussing how to achieve the most predictable and pleasant result. And all of them, they focused very nicely on the treatment planning, of course, with different views and taking care of different aspects, but it was very interesting.
Exactly. Do you recognize that dilemma, José, between time, speed, and perhaps risking inferior outcomes?
I do, and I think, as Luca said, that the main focus was on the treatment planning and how they now, all of them spend a lot more time on the actual planning phases than on the execution. So I would say that many of these people are spending 70% of their time, if not more, planning before, so that when they start their surgeries, they can have all the tools that they need to perform what they need to perform. And I think, for example, Ramon was showing in some of his cases how he takes a little more risk sometimes, and he lost an implant in one case, to do immediate placement, immediate provisionalization, basing on the fact that, he wants to do one surgical appointment only. So instead of doing the long waits for bone graftings to heal and soft tissue to heal and then implant placement and then provisionalizing, they try and compress it all into one surgical appointment. That was Ramon's case anyway.
Yeah, and I think this is a little bit, I would say, acritical. I mean, it looks like this is the only way, but then in the discussion we talked about it, and it came up that, of course, you cannot do this in all cases, and that there are prerequisites to be taken care of, and they described that pretty well. But they gave it for granted that, what we are doing nowadays is just when it's a terminal dentition, extract the teeth, place the implants, and go for an immediate restoration. That, of course, is complicated. It necessitates a very accurate planning, but can, in some instances, guarantee better outcomes, because the soft tissue management that you can achieve by doing everything at one time is for sure easier to manage.
So what I hear is that you say perhaps we've lengthened the treatment by taking more time for the planning, right? Mm-hmm. And now your session was about, well, if you take extended time in planning, how can we reduce that? Is that the key of this session?
I would not put it this way. I don't know if Jota agrees here. The thing is that if you want to reduce the timing of surgery, if you want to use this kind of approach, remove the teeth, place the implants, and restore it with a provisional restoration immediately, then you need a good planning.
Yeah.
And then,
if you want to go fast in surgery, then you better spend some more time in planning.
This is exactly how things are going, or how I envision it and how they are doing it. They're spending time with technicians and with, smile architects, with people that work with them in the clinics to design a protocol that they then do a surgical procedure in much less time, because everything is there ready, following every step.
And it's not only a matter of time, it's also a matter of predictability.
Absolutely.
And here what we have to stress is that the whole story here is not to have a shorter surgery, but to have a more reasonable healing period for the patient, because the patient comes in with a compromised dentition, and he comes out with a good-looking, efficient prosthesis in one surgical step. And this, for sure, it's a good thing for the patient, but we need to be sure that we can do this in a predictable way. So this is why I think that they gave a great message on how planning is important.
If I look at the first part of your title, we're not talking about single implants in the posterior. I mean, we're talking about full arch reconstructions. What are some of the extra challenges that those bring, and how were they addressed in the session?
Typically, the initial challenge is to know what to do with the dentition that's there, which in our eyes is saving teeth. That's what we want to do if we can. Now, we see a lot of these serial extraction cases where teeth that are very healthy are taken out, and we're completely against with that. But when you have teeth there that are salvageable, then you have to combine them with implants to do that reconstruction of a full mouth. Now, when that's dentition is completely gone or it's hopeless, then is when you can go ahead and plan for a full arch reconstruction, extract the teeth as you need, build the bone and the soft tissue as you need, and then put a provisional on.
So I think that all the speakers mentioned the fact that extraction is not something that you can do just because it's easier or because
just to make space for your full arch reconstruction.
They did not stress it anyhow, because I think from some aspect at the EAO this is given for granted, and I'm very happy to see this, that everybody here agrees that we are dentists, our first option is to save the teeth. Then, of course, there are situations where teeth needs to be extracted, but this has to be approached in a very cautious way.
Exactly. Now, I see, judging from the speaker titles, you talked about biological and mechanical considerations. You talked about the digital aspect of planning. But your third speaker, Florin Kofar from Romania, is also kind of our AI speaker in this Congress. He has the word artificial intelligence in his title. Is it helpful or not? How do you walk out of that room? What do we know about AI in dentistry at this moment?
I think Florin is a very smart thinker, an advanced thinker in everything he's done for the last decade or so. And the fact is that he has come up with a way of, taking a photograph of a patient and being able to allow a software to actually make a video out of a photograph that can show you the final result in 10 minutes or in 5 minutes. So it's a great tool to show the patient what can be achieved. But on the other hand, you then have to achieve that. And to achieve that goal, it takes a lot of expertise, and it takes very skilled people to be able to get there. So in my eyes, I don't know, Luca, what you think. I think these tools are only great and a good addition. I don't think they're bad in any way. They're great. But we have to make sure that the audience and people understand what it is that it takes to get to that final. Otherwise, we're overpromising.
Okay. The thing is that, technology is going forward every day, of course, and we have some tools that come to our attention. For instance, Smile Design came up maybe 10 years ago, but that was a static thing. You had a picture of the smile of the patient, and then you changed it, and you could show the patient. But of course, this does not fit with what our mouth is, because our mouth is a dynamic situation. You smile, you talk, you eat, and so this is the next step. It's not only a Smile Design, but it's a Smile Design that can be shown to the patient in a dynamic way. And I think that he mentioned mostly about this tool, but artificial intelligence is nowadays in all the CAD design things. There are several things. The dental technicians, when they design a restoration digitally, they have they have the opportunity, most of the softwares, to have a suggestion coming from the...
Based on the machine learning. And but how do you feel about José's worry that these type of tools might lead to over-promising and then in the end perhaps disappointment on the patient side?
I have to say that I'm an old guy, much older than so I'm always a little bit skeptical about this digital approach, even though I have the privilege to work with younger people and they are in love with this, of course. The thing is that what was not stressed in the session is that we still have a tool, an analogic tool, to show the patient effectively what the outcome is. And this is probably feasible in, I would say, 90-95% of the cases, because we could do a mock-up, Now, the case that was shown by Florin was showing a case that he said that all the teeth were mobile, so this was not possible. But this is the exception. So I think that as professionals, we should be able to use these beautiful digital technologies but also to combine them with something that is more foot on earth, you know.
Exactly.
So, but this is again the responsibility of the clinician and also the ability of the clinician. But I agree with what his.
I agree that we're in a mixed phase where there is analog and digital. But I am a strong believer that the digital is helpful. It's only a better thing. It's a better tool. But we need to know what our limitations are as clinicians, and at the same time know what the tool is good for and what not. You
speak from experience when you express this worry that people sometimes might be over-expecting?
Absolutely. I mean, even since the beginning of Smile Design that Luca told us before, which was a 2D analysis, not in 3D like they're doing now, but it was a mock-up taken to the mouth. When we started this in 2011, I think, was the beginning when I brought Christian Kochman to Europe and we started doing courses together. The reality is that you use a mock-up, you show the patient, but then you actually have to deliver what you've promised. And in my hands, not once, but several times, that became a difficulty through the treatment. Yeah. But the patient had already seen what I'd promised on the mock-up.
So and then or whatever happens in biology.
They come back and they're like, well, but you said that this would be like this. So you better make sure that you explain to them that this is our plan, our print, our architectural drawing, but it might not be 100% at the end of the day. But it's getting closer and closer to that.
Yeah. But that's why you underline this is in the hands of very experienced and knowledgeable clinicians. So if you're new in this field, don't just use the tool, use the AI mock-up and say, here, let's make magic happen.
Small word of caution.
Yeah. Makes sense.
I also think, Jota is a very experienced dentist, very intelligent person, and he's enthusiastic about these technologies. But and so I think he can manage, and most of the experienced young clinicians can do that. The thing is that we have the risk, and I think the EAO should underline this, that these technologies are used only as a marketing tool. And then
by dentists?
By dentists.
Yeah.
And then I don't know if this is something that will turn back on the professionals or not. Exactly. So, like everything, you need to be in the driver's seat properly. And I'm sure that...
Absolutely agree with you, Luca. Yes.
That Jota is there, but most of these technological innovations have created issues. For instance, my friend here showed the beautiful case at the beginning of a dentition that was not at all mutilated, that was not at all hopeless, that was completely all extractions, bone reduction, implant placement, and a restoration.
Wait. How do we go from not at all mutilated to completely extracted?
Because this is exactly my point.
That is the problem we're having. And
because what this...
you were showing that as a case like this is happening.
This is happening
in the clinic.
In the clinic.
Exactly.
And this is the problem, because 25 years ago, 30 years ago, this was impossible to perform. Now it's feasible. This does not mean that it has to be used in all cases. And this is what is happening, because this is what people are asking, the patients. And this is what many dentists are using as a marketing tool. Okay, but at the end of the story, this will create a long time problem for implant dentistry, because as Nitzen Bicaccio stated, all the restoration have complications in the long term. So our role is to delay the complication as much as possible. And if you start with a very aggressive treatment, you are reducing the chance for the patient to have a second option or a third option, especially if this guy is very young. I mean, if you have a 45-year-old...
this goes for many years.
The whole point of that case is showing what some people are actually doing out there to make the shortcut, or let's say be faster and predictable by extracting very healthy teeth and giving a final beautiful set of new teeth.
For 2 years.
But you're mutilating.
No, but it's not. It maybe might last for 20 years.
Yeah, it might, but that's the whole point.
But the thing is that it was not needed.
Yeah.
I mean, if you have a small problem in the knee, the orthopedic surgeon will not...
What happens when that fails? You know? That's
exactly. You have no escape. Yeah.
Okay.
Luca Cordaro, our job is to delay the complications as long as possible. That's an all other take on the profession, right?
Yeah, I mean, I have had the privilege in my life to work in a practice that will be 70 years old in 2 years. I have the third generation there working, and I think the success of a professional comes on how he treats the patients or the clients. Tell them how, name them how you want. And in this respect, you have to be sure that you are treating them in a fair way. And what I see is that in some cases, these technological improvements are just used as a marketing device. And this is, and I think the EAO is in the right track, because we are always underlining that, and all the speakers, I mean, I cannot tell Professor Bicciaccio what he has to say on stage, but it's nice. It's nice to see that when they come, this is the message they deliver. So
so that's very fitting.
Yes.
Now, finally, to make people super curious about either go watch those recordings of those 3 speakers or actually make a change in the clinic the next time they walk in. Jose, what do you hope that people take away from that session that you guys just shared?
I think it's a session that showed broadly what are the biological and biomechanical things that we have to consider in full arch. They also showed where the limits are of doing everything. How fast can we be? Can we really be that fast? So they showed the limits in a way too. And finally, you know, the last speaker gave us an insight on AI and its application to treatment planning. He focused basically
all the
on
way
that.
at the front of that journey, right?
Yes,
Yeah, that's true.
from the very beginning until the final.
It was
product.
fast. I think very interesting. I think that people would profit from listening to these speakers because they were concise. First speaker, for instance, he gave many valid points that are. It's nice to rehearse what we all should know.
Yes,
right.
yes.
Gentlemen, thank you so much for bringing that knowledge to this Let's Talk table, for chairing the session and all the hard work that both of you do and did for the EAO. And thank you for watching this episode. I can imagine you're only super curious, so go check out the full recording on Monaco Online, or check out some of these other Let's Talk sessions with chairs of the most talked about sessions here in the Congress. And if you happen to know any colleague, any friend, anybody who's involved in implant dentistry that could benefit from some of the key takeaways that were just shared here on this table, make sure you forward this video to them.